apologize for getting off the last PowerPoint. My one of my office mates got injured. Anyway, metabolic syndrome. Where we left off, we talk a little bit about fasting blood glucose, fasting lipid profile, urinalysis. And basically with metabolic syndrome, it's the ability of insulin to stimulate glucose disposal. It varies at least sixfold in healthy individuals. And approximately 1/3 of the population is most resistant to this action of insulin. And they are at greatest increased risk to develop a number of adverse clinical outcomes. Some of the therapeutic interventions to reduce the underlying causes is where NPs really do wonderful. You know, it's encouraging, motivational, interviewing, weight loss, exercise. We want to treat the associated lipid and non-lipid risk factors like hypertension, prothrombotic state, atherogenic dyslipidemia. Foods to avoid, we want to teach patients the very basics. You know, remember a lot of these patients that you are going to have don't have a lot of education. You got to educate them about high fructose corn syrup, get them to see a nutritionist. You want them to avoid refined sugar, flour, high intake of carbs, and salty, high-fat foods. Also, the people that are at most risk for metabolic syndrome are American Indian, African American, Hispanic, Asian. And what they found genetically when they did a genotype, that a lot of these patients have higher cortisol levels. I'm not sure why that is, but which affects a lot of the trans fatties. It also affects the phospholipid membrane. Also, patients who are on antipsychotics oftentimes have metabolic syndrome as well. So we wanted to teach patients on how to increase intake of bread, cereals, fruits, vegetables, dairy, fish, poultry, fats, oils, olive and canola, and Mediterranean diet type foods. So really changing in the macronutrient content of diets is a huge piece of helping patients with metabolic syndrome. And basically, the change in diet is going to will affect this compensatory mechanism where the body releases a lot of insulin based on what patients are eating. Indications for referral are resistant to therapy, dietitian referral, psychologist, and physical therapist. I can give you an example of a patient that I had who was extremely overweight. I put her on an antidepressant, and she was exercising, she was eating better. So that's just when you look at psychologists, that might be an issue for this patient, stress, and they're eating because they're stressed. So when we talk about high sensitivity C-reactive protein, that is a marker that tells us these patients are at increased risk. Low density lipoprotein as well. And then phospholipase A2, which is also, when that is elevated, is another increased risk, which if these are elevated, these patients really need to go on statins. So when we talk, I'm going to show you the handout, the Boston Heart. Basically, this is just talking about patients who have a higher risk of hyperlipidemia and the blood work that needs to be done. Inflammation markers are the C-reactive protein, the HCCRP, which is a more specific than C-reactive protein that we draw in the hospital. This is much more specific, so it's much more sensitive. Lipoprotein-associated phospholipase A2-LP. This is an enzyme produced by the monocytes, macrophages that break down phospholipids. Increased blood levels associated with increased arteriosclerosis. We want a range less than 200. Borderline is 200, 235, and high risk is greater than 235. Promotion of weight loss. And C-reactive protein is a protein produced by the liver in response to systemic inflammation. The highly sensitive CRP test is needed to detect low levels of CRP that may be seen in vascular or systemic inflammation. A CRP reported greater than 8 would signify acute inflammatory illness. The CRP HS is 10 times more sensitive, but it's very expensive. Promoting weight loss, counseling on nutrition, harmful health behaviors, which we would do in all type of patients, the metabolic syndrome type of patient and the patients who are overweight, who have high blood pressure as well. So when we talk about these new guidelines, the article, I have a couple articles online that talk about it. The new American Heart, American Cardiology, cholesterol guidelines, the treatment focus is on lowering risk of heart disease, revising target LDL, increasing levels of HDL, or targeting treatment goals in adult patients. So the goal really here is lowering the risk of heart disease. This is like an example of multiple choice question. So the answer is lowering risk of heart disease. The guidelines questions, the new guidelines recognize that superior treatment results may be achieved by lowering dose of statins combined with diet change, promoting specific lipid level goals, lowering dose statins, which also lower the risk of diabetes and myopathy, or more intensive treatment with statins. And the answer is more intensive treatment with statins. The new guidelines differ from previous guidelines in that they are more extensive and detailed in their focus on whom to treat, what to treat, and how intensively to treat, especially in the treatment of males ages 55 and over, by proposing different treatments for men and women. And the answer is in that they are extensive and detailed. The new American College of Cardiology, American Heart Association lipid guidelines does not address physical activity, heart healthy diet, pharmacologic treatment of hypotriglyceridemia, or tobacco use, and it's the treatment of high triglycerides. The characteristics of the 4 major groups of patients for whom statin treatments outweigh the risk include all except a 7.5% 10-year risk of arteriosclerotic cardiovascular disease, an LDL of 70 to 189 without diabetes, a primary LDL level of 120 to 189, type 1 and type 2 diabetic 40 to 75 years of age with LDL 70 to 189, and evidence of arteriosclerotic cardiovascular disease as defined by acute coronary syndrome. And the answer is primary LDL levels of 120 to 189. Which statement about the cardiovascular risk calculator is accurate? It has been prospectively tested for accuracy. It may underestimate risk. It is consistent with best medical practice, likely to be updated in the future. And the answer is it may underestimate risk. High-intensity statin therapy is not recommended for high-risk patients, not recommended for patients with previous MI, helpful in reducing the severity of developing myopathy, and is designed to reduce LDL by more than 50%. And the answer is designed to reduce LDL by more than 50%. A patient who does not qualify for one of the 4 major risk groups should be offered a statin therapy if he has a primary LDL of 160 or greater, has a high sensitive C-reactive protein of 1 milligram or less, has a coronary artery calcium score of 175 units or greater, or has an ankle brachial index less than 1.5. And the answer is a primary LDL of 160 or greater. All patients starting statin therapy should receive each of the following except a thorough history and physical, liver function tests, renal panel, education, lifestyle modification, or CK levels. And the answer is CK levels. Lab tests for a patient on statin therapy at risk for adverse muscle events should include LDL cholesterol level, CK levels, hepatic function panel, or lipid panel. And the answer is CK levels. Which diagnostic test is ordered when a patient on a statin therapy experiences unusual fatigue, abdominal pain, and dark urine? And the answer is liver panel. The statin dose of a patient with hepatotoxicity can be decreased if 2 subsequent readings of LDL are less than 40. Urine myoglobin indicating statin intolerance is one sign of rhabdomyolysis. Which is a predisposing condition for statin intolerance? Hyperthyroidism, hypothyroidism, hypercalcemia, or hypocalcemia? And the answer is hypothyroidism. When symptoms of statin intolerance resolve, restart the patient on his regular statin dose once a week, wait for 4 weeks before restarting the patient on his regular statin dose, start the patient on a lower statin dose 2 to 3 times a week, or use alternative methods of reducing cholesterol. You want to start the patient on a lower statin dose 2 to 3 times a week. And the new guidelines point to which statin treatment for a non-diabetic 45-year-old white male with total cholesterol of 270 who smokes, is not on an antihypertensive, and has a 10-year risk of arteriosclerotic cardiovascular disease of 12.5. And it's high-intensity statin. The new guidelines point to which statin treatment for non-smoking, non-diabetic, 46-year-old black female taking antihypertensive with total cholesterol of 240 and a 10-year risk of arteriosclerotic cardiovascular disease of 4.5. And the answer is no statin. So that's the end of this. I'm sorry I had to do it in 2 PowerPoints, and I am looking forward to seeing you in class.